Most acute viral infections follow a predictable single-peaked curve. A patient's temperature rises as the immune system engages, hits a climax, and then steadily resolves back to a normal baseline. But there is an anomaly, a fever that peaks, then crashes completely, creating a false sense of recovery. Just as the patient feels they are in the clear, the temperature violently erupts a second time. This biphasic pattern is known clinically as the saddleback signature. It is the defining physical hallmark of dengue, a disease historically referred to as breakbone fever for the severe systemic pain it inflicts. The virus reaches human hosts through a specific biological vector, the female Aedes aegypti mosquito, which transfers the pathogen directly into the bloodstream while taking a meal. The core clinical dilemma with dengue is that in its first few days, it perfectly mimics dozens of other benign respiratory and viral infections.
To confidently identify it, a clinician has to map the exact chronological presentation of symptoms and hematological markers over a strict 10-day period. Recognizing the disease early is the only way to intervene before that secondary fever spike triggers catastrophic vascular complications. Mastering this chronological timeline gives physicians the precise tool they need to isolate dengue from a dense cluster of look-alike illnesses. This timeline tracks a patient's temperature alongside their physical symptoms across 10 days. Before day 0, there is a silent incubation period. For 5 to 10 days following the initial mosquito bite, the virus replicates without triggering an immune response. That silence ends with a sudden, violent physiological reaction. On day 0, the temperature spikes acutely, accompanied by chills, rigor, and profuse sweating. This initial fever brings the characteristic breakbone pain profile. Patients experience severe aching deep within their long bones, a throbbing frontal headache, and intense pain located directly behind the eyeballs. This skeletal pain is compounded by autonomic and gastrointestinal symptoms, namely nausea, vomiting, and anorexia, leaving the patient in a state of total physical prostration. Looking at the established medical literature on the clinical features of dengue, we see this exact triad recorded: severe frontal headache, pain behind eyeballs, and intense generalized aches. Yet, despite the severity of this pain, a day 1 presentation lacks an exclusive marker. It is easily and frequently misdiagnosed as severe influenza. Without a definitive diagnostic sign in this first phase, the clinician must watch closely for the physiological shift that occurs on day 3. On the 3rd day, the temperature plummets back to the baseline. For the next 24 to 48 hours, the patient enters an afebrile interval. The intense headaches and joint pains temporarily subside. Then, usually on day 4 or 5, the fever reignites. This secondary spike completes the saddleback curve on our timeline. This biphasic structure is the clinical alarm bell. Very few acute viral infections feature this deliberate pause and resurgence, hands and feet. It moves in a centrifugal trajectory, spreading rapidly upward along the limbs before engulfing the trunk. During this phase, taking the patient's pulse reveals a paradox.
Even as their body temperature climbs, their heart rate drops, a condition known as relative bradycardia. A physical exam at this stage will also reveal generalized lymphadenopathy, with swollen nodes presenting across multiple sites. The sudden intersection of a returning biphasic fever, an ascending rash, and relative bradycardia provides the clinical certainty needed to rule out standard respiratory infections. Clinical suspicion must now be confirmed by laboratory data, specifically by analyzing the patient's white blood cells. The blood picture typically reveals a drop in the overall white blood cell count, accompanied by structural abnormalities within a specific type of immune cell called polymorphs. This textbook reference shows the precise diagnostic criteria: leukopenia with toxic granulation of polymorphs. The laboratory data may also reveal secondary organ strain, specifically decreased urine output, known as oliguria, and the presence of albumin protein in the urine. These systemic findings mark a critical threshold. They indicate the potential transition from standard dengue fever to the much more dangerous dengue hemorrhagic fever. This severe form is driven by a viral hypersensitivity that triggers disseminated intravascular coagulation. The coagulation system misfires, creating microclots while simultaneously damaging the vascular walls, allowing plasma to leak out. The result of this vascular breakdown is visible on the patient. They begin hemorrhaging under the skin and bleeding directly from their mucous membranes. This systemic collapse can also invite secondary issues, including severe bronchopneumonia and infections of the middle ear. Tracking the initial drop in white blood cells is vital. Once the disease transitions into severe hemorrhagic shock, a manageable febrile illness rapidly becomes an immediate life-threatening medical emergency. In uncomplicated cases, the fever breaks and the disease naturally resolves within a span of 6 to 10 days. However, the prognosis shifts unfavorably for patients of advanced age or those carrying pre-existing heart, brain, or kidney diseases, where the physiological strain can be overwhelming. This table compares dengue and its mimic, influenza. Influenza localizes pain to headaches and eyes, while dengue causes severe pain in the long bones. Finally, the biphasic saddleback fever is marked definitively present for dengue and absent for influenza. Because the disease is inherently viral, managing dengue must start long before the point of infection, focusing entirely on proactive environmental prevention. Public health efforts historically centered on breaking the chain of transmission by deploying mobile abatement teams to eradicate the mosquito vector in populated areas. For the infected patient, there is no specific cure. The core protocol relies on strict at-rest and rigorous fluid management to counteract severe dehydration. Historically, clinicians administered sodium salicylates, compounds like aspirin, to manage the intense breakbone pain. Modern medicine heavily restricts the use of these NSAIDs in dengue patients. Because these drugs inhibit platelet function, they severely amplify the risk of internal bleeding if the patient enters the hemorrhagic phase. Diagnosing dengue requires moving past initial symptoms and waiting for the distinct clinical triad to emerge, recognizing the deceptive biphasic fever curve, identifying the deep skeletal myalgia, and confirming leukopenic markers in blood.